Hello, these are disorders of lipid and lipoprotein metabolism presented by the SchrDbb, also called Dassi Bopda reference chemical pathology lecture notes of University of Cape Town. So here we're going to continue the tutorial on lipid metabolism disorder. So here we need to know that what the disorder, as we have already said, disorder of lipid metabolism are going to be divided into primary hyperlipidemia and secondary hyperlipidemia. Now, under primary hyperlipidemia, it consists of familial hypercholesterolemia. We say that in primary, there is no particular etiology of the cause, so it is more of genetic cause. Is it clear? While in secondary, there is an etiology why there is a profound etiology for the hyperlipidemia. So that's why generally the primary hyperlipidemia are the ones that are going to have the word familial or genetic or the different one. So we have familial, and we say that generally hyperlipidemia is going to be divided into three. We have the first one, which is going to be hypercholesterolemia. The second one is going to be hypertriglyceridemia, and the third one is going to be mixed hyperlipidemia. Now, generally, now need to know that the disease of the hyperlipidemia are going to be divided based on these two molecules, triglycerides and cholesterol level. Is it clear? Now, because the different lipoproteins are only used there for the transfer of these molecules. Is it clear? But the main one that is going to cause the disease is either it's the triglyceride or it is the cholesterol. Is it clear? That's why the hyperlipidemia disease are based on these two names. Now, the first hyperlipidemia disease is familial hypercholesterolemia. The second is familial binding defecting apolipoprotein B100. The next is autosomal recessive hypercholesterolemia, polygenic hypercholesterolemia, familial combined. In combined hypercholesterolemia, we have both increased level of triglycerides and you have increased level of cholesterol. You have familial dis-beta lipoproteinemia, you have familial hypertriglyceridemia, familial lipoprotein lipase deficiency, and all that. Now, in cases of secondary hyperlipidemia, you have things like hypothyroidism, you have things like renal diseases, and you have things like liver diseases, diabetes, alcohol, and obesity. Now, the next is hypolipidemia. So hypolipidemia is another property that you can have here. So in hypolipidemia, you can have a beta lipoproteinemia. You can have familial hypobeta lipoproteinemia. You have analpha lipoproteinemia, which is also called tanglers, and we have the lecithin cholesterol acyl transferase deficiency. So now the hyperlipidemia is going to occur much more than the hypolipidemias. Is it clear? So now in primary hyperlipidemia, we start with the familial hypercholesterolemia. It is an autosomal dominant inherited disease of the low density lipoprotein receptors. Is it clear? Now we need to know that the frequency of heterozygote, I'm not going to speak about that one, is going to be based on genetics, but you need to know that you need to know that the results of the low density lipoprotein, you need to know that there is a failure of receptor mediated internalization of the low density lipoprotein that is going to result in failure to downregulate the HMG-CoA reductase at a normal cholesterol level. Is it clear? So actually the receptors that are supposed to reuptake low density lipoproteins, so the receptors for binding of low density lipoproteins have reduced. Is it clear? And the receptors of low density lipoproteins are found at the level of the liver. Is it clear? So at the level of liver, you have receptors for low density lipoproteins. Since these receptors are abnormal, they are not binding low density lipoproteins, the liver thinks that there is no low density lipoproteins containing cholesterol. Is it clear? So that's why now the action of the HMG-CoA reductase, which is involved in the production of cholesterol, is not going to stop. You are going to have continual production of cholesterol. Is it clear? And when you have continual production of cholesterol, you are going to have familial hypercholesterolemia. Now, to treat it, the homozygous, usually the people who are heterozygote may have some normality, but the people who are going to have very huge problem are the people who are homozygote, because an autosomal dominant disorder. Is it clear? So the next one is that the people who are homozygote, they have should take low fat diet and the drugs that is going to inhibit the HMG CoA reductase. Is it clear? So example are the statins. Example, you have simvastatin, you have atorvastatin. Is it clear? Atorvastatin. Now, the next one, you have familial binding defective apolipoprotein B100. Is it clear? From the name, you already know that it's an apolipoprotein. It's a defective apolipoprotein B. Is it clear? B100. And you need to know that what apolipoprotein B100 is more involved in the clearance of the LDL. Is it clear? This apolipoprotein B100 is involved in the clearance of the LDL. So this apolipoprotein protein involved with the clearance of the LDL. So what is going to happen is that you are going to, since there is no apolipoprotein B100, there is not going to be any clearance of the LDL. Is it clear? And when there is not going to be any clearance of the LDL, you are going to have hypercholesterolemia. The LDLs are going to accumulate in blood, which is going to result to hypercholesterolemia. So it's a predominantly inherited disease. Is it clear? It's found in family history, mostly in South Africa. Now the next one is autosomal recessive hypercholesterolemia. As we already know, it is autosomal recessive. Is it clear? Only present in homozygous patient. Is it clear? Now in this case, what happened is that it's a hypercholesterolemia which occur because of still abnormality of the LDL receptors. So the LDLs do not find that there is high level of low density lipoproteins in blood, so low density lipoprotein is going to accumulate. So this autosomal recessive hypercholesterolemia is just like familial hypercholesterolemia, so they are just similar. But in this case of autosomal recessive, in this case it's going to be autosomal recessive, while familial hypercholesterolemia is autosomal dominant. Now you have also the polygenic hypercholesterolemia. So this is a category that is going to account for a majority of patients of low density cholesterol. Is it clear? So in this case, you are going to have majority of patients are going to have high level of low density cholesterol. Is it clear? The pattern of inheritance is by a single gene defect. I'm not going to speak about that, but you need to know that generally in this patient you're going to have a very high number of low density cholesterol that is going to cause the accumulation of cholesterol, and the treatment is still based on the diet. This patient should be deficient, should take diet deficient in lipid. Now we have familial combined hyperlipidemia. In this case, we have both increased level of cholesterol and increased level of triglyceride. Is it clear? So when you have both increased level of cholesterol and triglyceride, it's because of increased secretion. So it's a subgroup have overproduction of ApoB proteins. Is it clear? So you are going to have increased secretion of very low density lipoproteins, and you have also high level of intermediate density lipoproteins. Is it clear? So intermediate density lipoproteins and very low density lipoproteins, which constitute approximately the same amount with triglyceride and cholesterol, are going to be high, unlike an increased level of low density lipoproteins alone here. Is it clear? Now there's the next one, which is familial beta lipoproteinemia. There's another one which is familial hypertriglyceridemia. So I'm going to speak about familial hypertriglyceridemia. It's a common autosomal dominant defect causing the increased level of very low density lipoproteins. You need to know that when you have hypercholesterolemia, the major element which is involved is the low density lipoprotein. Is it clear? And when you have high level of triglycerides in blood, the major element which is involved is very low density lipoproteins. So you have very low density lipoproteins that is going to be very high, and the basic defect here is going to be decreased catabolism of the very low density lipoprotein, which is going to make the triglycerides to increase. Is it clear? So this type of people are going to be very fatty. Is it clear? So now you need to know that they are going to be very fatty and they are often asymptomatic. So the patient only become hyperlipidemic post-puberty and they are often asymptomatic. Higher level of triglycerides generally is not going to cause atherosclerosis. What causes more atherosclerosis is high level of cholesterol. Is it clear? Though triglycerides may cause atherosclerosis, it does not cause usually than cholesterol. So the elevated triglycerides are not a risk factor for coronary artery disease. I hope you're understanding. So atherosclerosis is reduced, but slightly increased cholesterol and low density lipoprotein and low of high density lipoprotein are the risk. So xanthomatas in this patient are not present. So when you have high triglyceridemia, you don't have any xanthomata. Clinically, these patients are often obese. So this type of patient, mostly they are going to store their triglycerides, so they are going to be obese. So they have high glycemic and insulinemic and may also be hyperuricemic and have hypertension. So these are typical type of patients that are going to have the syndrome X, is it clear, or the metabolic syndrome. So avoiding estrogen preparation and all that. So now the next is familial lipoprotein lipase deficiency. So you have seen the role of lipoprotein lipase, which is involved with the breaking down of the chylomicrons such that the triglycerides can be utilized. So when this lipoprotein lipase does not function, you're going to have high level of triglycerides in blood and you have high level of chylomicrons in blood. So you have all that disease still involved there. So we are not going to speak about that. The next disease you're going to see is secondary hypertriglyceridemia. Okay, now we continue with secondary hyperlipidemia. Now we need to know that what this accounts for about 40% of hyperlipidemia and affect about 5% of adults. Is it clear? Now you need to know that what it consists of one, hypothyroidism. So in hypothyroidism, you're going to have decrease in catabolism of hypothyroid hormone is involved with maintaining basal metabolic rate. When you have a decreased thyroid hormone level in hypothyroidism, you're going to have a decrease in metabolism of. So that is the case of hypothyroid. In hypothyroidism, you're going to have decrease in the metabolism, the catabolism of VLDLs, the IGLs, and LDLs. Is it clear? So you are going to have predominantly hypercholesterolemia. Is it clear? Because the catabolism of LDL is going to predominate all of those with normal or slightly raised triglyceride level. Now the next is renal disease. You need to know that in renal disease such as nephrotic syndrome, you have the loss of albumin. Is it clear? Now to compensate the loss of albumin, what happens is that the liver is going to secrete, is going to produce more of cholesterol. You are going to have hypercholesterolemia. Is it clear? In order to compensate that. Is it clear? Now the next is a liver disease. In the case of liver disease, in cholestasis, is it clear? When you have an obstruction of the biliary system, what happens is that the bile cannot be excreted, and if bile is not excreted, when you have cholestasis, you have bile, cholesterol, and phospholipid is going to enter the bloodstream, and you're going to have severe hypercholesterolemia and variable hypertriglyceridemia. The next one is the diabetes. As we've said that what in diabetes you cannot utilize your glucose. Is it clear? So what happens is that you are going to have more of the triglycerides and cholesterol which are going to be released inside the bloodstream. So diabetes is going to be characterized by overproduction of VLDL that is going to result to hypertriglyceridemia, and prolonged insulin deficiency is going to reduce the lipoproteins activity, and if the VLDLs rise markedly, the chylomicron are going to accumulate, competing the lipoprotein. Is it clear? In a well-controlled diabetic patient, there is going to be a mild triglyceridemia. With poorly controlled diabetic patient, you have severe hypertriglyceridemia, and you have also chylomicronemia. which can result to an acute pancreatitis. That's why you need to know that the major incidence of triglyceride, have severe high triglyceride level, is going to be pancreatitis. Is it clear? Now the next one is going to be alcohol. Usually you need to know that usually causes of hypertriglyceridemia is going to be increased synthesis of VLDLs. Is it clear? And hepatic triglyceride synthesis is going to increase due to fatty acid oxidation as a result of alcohol, because alcohol is going to increase the acetyl-CoA production, is going to increase the triglyceride level. Is it clear? Now the next is going to be obesity. Increased fatty acid delivery to the liver is going to result to increased VLDL synthesis and occasionally increased conversion of the LDL synthesis. So obesity is also going to result to high level of VLDL and LDL in the body. Is it clear? So this is the summary of the different diseases. So when you have the difference, the primary and secondary diseases, you have the race different levels. So in different diseases, you have a type 1. This hyperlipidemia are divided into type 1, in type 2A, type 2B, type 3, type 4, and type 5 hyperlipidemias. Is it clear? Now the type 1 in the case of a type 1, you have an increase only in chylomicrons, and when the chylomicrons are increased, you have increase in triglycerides. In case of type 2A, you have increase in LDLs, that's increasing in cholesterol. In case of type 2B, you have increase in LDLs and VLDLs. So you have both a mix, both an increase in cholesterol and increase in triglyceride. That's similar with a type 3, where you have an increase in IDL, where you have both increase in cholesterol and triglyceride. Now in type 4, you have increase in VLDLs. Is it clear? Where you are going to have an increase in triglyceride. And in type 5, you have increase in chylomicron and VLDL. So these are the different types of diseases, and those type of disease can be classified under primary and secondary hyperlipidemia. Now based on this, you can easily have classification of different diseases. Now primary hyperlipidemia is going to consist of familial lipoprotein deficiency, apolipoprotein C, which is going to be under type 1. Under type 2 we have different, under type 3, under type 2B we have this, under type 3 we have this, and type 4 we have that, and type 5 we have that. So generally, in order to summarize all the hyperlipidemia disease, you can just use this your table for you to have all of them in mind. So now the next one is hypolipidemia. So the first case of hypolipidemia is an beta lipoproteinemia. Is it clear? So it's a defect in the synthesis of apolipoprotein B. So you are going to have a mutation, may be a homozygous mutated MTT, that's mycosomal triglyceride transfer protein. So when you have a mutation in the mycosomal triglyceride transfer protein, you cannot transfer triglycerides from one chylomicron, from one apolipoprotein to another. Is it clear? So it's going to prevent the synthesis of chylomicrons. Is it clear? When chylomicrons are not produced, you don't have the transfer of triglycerides and cholesterol to the different part of the body. We have also familial hypo-beta lipoproteinemia. Is it clear? So it's defined as by a plasma level of total cholesterol or LDL or total ApoB protein to be below the 5th percentile. Is it clear? So when you have a very low density, when you have low level of cholesterol, LDL cholesterol, you have familial hypolipoproteinemia. In the case of an A-beta lipoproteinemia, you have a low level of triglycerides. But in the case of familial hypo-beta lipoproteinemia, you have low level of cholesterol. Now, an alpha lipoproteinemia is where you have absent HDLs. So in case where you have absent HDLs, the defect is going to be an ABC transporter defect. The HDL is not going to be found, so you are going to have no accumulation of cholesterol and all that. And the last one is lecithin CAT deficiency. So in lecithin cholesterol acetyltransferase deficiency, you don't have the transfer from one apolipoprotein to another. You don't have the transfer of cholesterol esterase from one lipoprotein to another. Since it cannot transfer cholesterol esterase, you are not going to have enough cholesterol in blood. So how do you treat hypolipoproteinemia? So you need to know that generally the patients, so to treat this patient you have to give, so does the treatment aim at improving the lipid profile, and it does to decrease the incidence of coronary artery disease. Is it clear? So in hereditary hyperlipidemia, the aim is to reduce the lipid profile, while in the cases of a hypolipidemia, you want to increase the lipid profile. So how do you treat? In the case of treatment, you can use diet. You can advise. So in the case where a patient has a hyperlipidemia, the diet, you have to advise the patient to reduce the total caloric intake, reduce the total fat content. You have to reduce the saturated fat. So because saturated fat is going to when you have saturated fats that are having only carbon bonds which are single bonds. Is it clear? Carbon to carbon bond are only single bond. Those are saturated fat. Is it clear? And then you have to increase mono and polyunsaturated fat, because mono and polyunsaturated fat are very good for the human body. Saturated fat, which is only made up of carbon to carbon single bond, is very bad for the human body. Is it clear? So you have to reduce the dietary intake of cholesterol. You have to reduce the excess body weight, avoid excess alcohol, and also avoid excess salt, because all those are involved with causes of hyperlipidemias. Now in the case of drugs, so you have to consider drug treatment. In moderate hyperlipidemia, which is unresponsive to diet, it's only when you have the hyperlipidemia which is unresponsive to diet that you can use drugs, or you can have a patient that has a high risk of having a coronary artery disease, or you have a patient with a familial history of. So drugs are used when you have moderate hyperlipidemia, which is unresponsive to the diet for 3 to 6 months. Drugs are used when you have severe hyperlipidemia. Drugs are used when you have any degree of hyperlipidemia with a coronary artery disease, and when you have any inherited hyperlipidemia. So these are examples of drugs that can be used. The first drug, you have statin. Statins are HMG-CoA reductase inhibitor. You have examples simvastatin, you have atorvastatin. Is it clear? And they are going to inhibit the rate of production of cholesterol. So in this case, they are going to reduce both cholesterol and LDL. Now the next one, we have cholestyramine. Now cholestyramine is a bile acid sequestration. It's going to sequester bile acid so that it can be released easily in the bile. So it's going to bind with bile acid, the GIT, and it's going to reduce now the enterohepatic circulation. Is it cholestyramine, such that cholesterol should not get back into the circulation. That's going to reduce cholesterol and low density lipoprotein cholesterol. Now the next one is nicotinic acid, which is also vitamin B3. It's going to inhibit lipolysis from the adipose triglyceride. So the adipose tissue triglyceride, we usually can do lipolysis for production of fatty acid, which can be mobilized. Is it clear? Now you need to know that the nicotinic acid inhibits the lipolysis, and thus is going to lower the total low density cholesterol. Also lowers the triglyceride for somebody that has high level of triglyceride with a risk of having acute pancreatitis, and also who is going to be obese is going to have this. So you use nicotinic acid that can inhibit that. We have also raised HDL cholesterol. Now we have probusol. Probusol is a lipid soluble antioxidant, and it's going to reduce the oxidation of low density lipoprotein. Now we need to know that what low density lipoprotein itself does not cause atherosclerosis. Is it clear? What causes atherosclerosis is oxidized low density lipoprotein, which is located at the level of the tunica intima of the blood vessels. Is it clear? Because this, what is bad on oxidized low density lipoprotein is that oxidized low density lipoprotein cannot be broken down. Is it clear? So this probusol reduces the oxidation of low density lipoprotein, so it can help you to convert an oxidized low density lipoprotein back to a normal low density lipoprotein, such that it can be broken down by the macrophages. What you have to note is that macrophages cannot break down low density lipoproteins after engulfing it. Is it clear? It can only break down, it cannot break down oxidized low density lipoprotein. It can only break down low density lipoproteins. Is it clear? So this pulbisol is going to convert, going to reduce oxidized low density lipoproteins. Is it clear? Now the next one is that we have fibrate like gemfibrozil. Is it clear? Which is going to reduce the synthesis of VLDL and increase low lipoprotein L activity. So these are the approach of the treatment. So if you have hypercholesterolemia only, you can use statins alone. You can use statins plus bile acid secretion. You can use bile acid secretion alone if resistant to statin or in children. Is it clear? You can use fibrates, which is preferable combined with statins, and you can also use nicotinic acid alone. If the patient has hypertriglyceridemia, you use fibrates, you use nicotinic acid, and you use statins. Is it clear? So from here we have finished generally with all disease involved with hyperlipidemia. So say thanks for your kind attention. Don't forget to like and subscribe for our channel, Science Maker. Thank you.